Welcome everyone to today's APSC Journal Club series, Hot Topics in Cardiology. Today we're talking about revascularization in ischemic cardiomyopathy. This event is organized by the APSC Emerging Leaders, endorsed by the Singapore Cardiac Society, EBAC accredited for CME points. The date stamp today is the 10th of November 2022 on a Thursday, 6 p.m. Singapore time. My name is Jack, the head of cardiology at the National Heart Centre Singapore, your chair for today. And with me is my good colleague, Professor John Yap, the lead for the APSC Emerging Leaders, also at the National Heart Centre Singapore. We have three speakers. Dr. Orlanda Goh from SGH is going to talk on evidence-based medicine teaching, just a primer for today's session. Dr. Ivan Wong, Interventional Cardiologist at QE Hospital, Hong Kong, is going to talk about the STICHES trial. Dr. Cader from Bangladesh, Dhaka, is going to talk about the Viability 2 trial. We're very privileged to have three esteemed panelists, respectively, Professor Philip Pang, the Deputy Head of the Cardiothoracic Unit at National Heart Centre, Dr. Matthew Ryan, Clinical Lecturer at King's College, UK, who's also a co-author for the Viability 2 trial, and Professor Quan Lee from Tucson, Arizona, USA. A pitch for upcoming webinars on the 19th November, we have an APSC Emerging Leaders CHIP Summit on Complex Left Main Interventions. A disclaimer, this content is copyrighted by the APSC. The views expressed here solely belong to the faculty members. The webinar is currently made live stream by Wonder, APSC Facebook and YouTube pages. CME points will be submitted for those who are connected throughout the full duration of this Zoom webinar after completing a survey sent by email. Please click onto the Q&A box below if you have any questions to ask. So let's get started. And before Dr. Cader talk about the Viability 2 trial, we have Dr. Orlanda Goh speak to evidence-based medicine. John will give a primer for today's session objective. John, please. So John, can you?
Thanks, Jack. Just a very quick introduction to today's series. This is brought to you, one of the initiatives brought to you from the APSC Emerging Leaders Group. And I just want to highlight some of the objectives that we hope to achieve with today's session. Number one, we hope that you acquire key knowledge on the current hot topic, and today's hot topic is revascularization in ischemic cardiomyopathy. More importantly, we hope that you will learn and be able to apply some of these fundamental evidence-based medicine concepts, and that will hopefully enhance your ability to critically appraise research publications. Just a quick intro to the format. This APSC Journal Club series is held once every 2 to 3 months, where we address a key topic in cardiology, something new that we're going to introduce from subsequent sessions. We're going to have a short talk on some evidence-based medicine principles by an expert in the field, and today we are glad to have Dr. Orlanda Goh with us. And after that, we will go through 2 main publications, and there'll be a commentary by senior experts. So without further ado, can I invite Dr. Orlanda to give us a short talk on some parts of our evidence-based medicine teaching. Orlanda, please.
Thank you. Thanks for the introduction. So I'm sharing screens. Okay, before I start, can I just confirm that everyone can see the screen?
Yes, we can see and hear you.
Okay. All right. Okay, I would like to thank APSC for inviting me to speak today. So this is a talk that I will give mainly to touch on some of the EBM principles that I thought would be good to know about based on the studies that we are talking about today. So just as a recap, thinking about it from the methodological perspective, for the first paper, I think if we were to summarize it in one question, we would say among those with ischemic cardiomyopathy who undergo CABG as compared to receiving medical therapy only, to those who have myocardial viability have better outcomes than those who do not. And as for the second question, what we're asking is among those with ischemic cardiomyopathy and myocardial viability, does PCI improve outcomes? So thinking about these questions, how then do we go about the statistical methods? So I think if we were to zoom in on the methods section for the first paper, you can see some of the keywords that I've highlighted here, which is basically them doing comparisons of the incidence of death from any cause. And this was performed with the use of multivariable Cox proportional hazards models that were adjusted for relevant baseline covariates, and survival curves were generated with the use of a Kaplan-Meier estimate. If you zoom in at the statistical methods for the other paper, we see that they did unadjusted time to event analyses to evaluate outcomes. And you see it also says the primary analysis included data from each patient up to the date of the outcome event, last follow-up visit, or withdrawal of consent. Hazard ratios with 95% confidence intervals were calculated with the use of a Cox proportional hazards model, and cumulative incidence was calculated with the use of Kaplan-Meier estimates. So what I'm driving at really is this theme of using Cox proportional hazards model and a Kaplan-Meier estimate, and this is what we'll focus on today. And whenever we see a term such as Kaplan-Meier estimate, we expect to see a survival time graph like what we see here. And I will take you through some of the basic concepts related to that today. So this brings me to the concept of statistical reasoning, meaning that if we were researchers or critical appraisers looking at a journal, how do we make sense of the statistical methods used? Or in other words, if we were to design a study, what do we understand of the value of some of the models used and how do we apply it? Okay, so for today, we would like to focus on this core question, which is what is a multivariate Cox regression model? What is a survival time or Kaplan-Meier graph? And what does it actually mean in terms of the results, in terms of how we talk to our patients or discuss the result or the impact of the paper with each other? So as an introduction to regression methods, one simple phrase that or line that can explain it would be that a regression provides a framework for comparing means, proportions, or incidence rates between two or more groups, depending on what our outcome of interest is. And this, therefore, can be done through linear regression models, logistic regression models, or Poisson or Cox proportional hazard models, respectively, depending on the outcome of interest we're looking at and what kind of a variable it is. So when we say simple regression models, we therefore just refer to analyses with only one predictor of interest, whereas multiple regression models refer to analyses with multiple predictors or covariates. So I think by looking at this, then we recognize that in most of the statistical methods sections in papers that we read, they will start off talking about the outcome of interest that they define, and then the application of a regression model that starts with the simple and then a multiple regression model that corrects for covariates, or in other words, confounders. And therefore, if we're talking about this framework, what does it actually mean? So this brings me to the concept of the regression equation. And if you recall from algebra or perhaps secondary school math, we have this equation y equals mx plus c, which refers to a two axis and then a line that has a gradient that is the function that links two variables. So this is essentially the basic structure of regression models. This is a linear equation, and basically the function of the outcome is the y, and then with the intercept plus the slope multiplied by x1, which is the first covariate, for example. Okay, so this is the mathematical notation that we might use to describe it. So x1 is our predictor of interest, basically the exposure or the outcome, the variable that we might want to change. And the right-hand side, B0 plus B1 over B1 times X1 includes the predictor of interest X1. The predictor of interest can be continuous, binary, or categorical, as I alluded to earlier. And then the slope B1 is actually the change in the left-hand side corresponding to a unit increase in X1, meaning for every unit change in our covariate, for example, whether a person is male or female, or whether there's myocardial viability or not, or what is the change that we expect in the outcome. And that is actually the coefficient. So left-hand side depends on what the variable type outcome of interest is. So when we're talking about Cox regression models, it's basically the name of the kind of equation we have when we have time to event outcomes, where the individual event and the censoring times are not known. So Y is a yes/no indicator of whether the event has occurred in the common follow-up period. And the left-hand side is actually represented by a ln incidence rate, and the regression type is a Poisson regression. And for time to event outcomes where the individual event and censoring times are known, Y is the outcome taking into account both the time and whether the regression type is a Cox and whether the event occurred. So similarly, it's a ln function. In the interest of time, I'll just quickly show you that this is the equation. And when we look at it, what it means is that the exponentiated slope is the estimate hazard ratio of the outcome for two groups who differ by 1 unit at any point in time in the follow-up period. Sometimes you see the term proportional hazards in this method section, which is basically something that we need to mention as the common assumption behind any Cox regression analysis. So it basically means that at any given time, T, the difference between the ln hazard between any two groups with different X values is constant and the multiple of the slope. And on the exponentiated hazard scale, this constant difference on the ln scale translates to a constant hazard ratio across the entire follow-up period. So if you would do a check, if you're doing a statistical analysis, you basically want to see that the relationship between the variables is constant throughout the entire period of analysis. So what did it actually mean to hazard the instantaneous risk of having the event at a given time in the follow-up period, or the time-specific risk of having the event of interest, or the time-specific incidence? And finally, when we look at papers, we see that this is frequently reported alongside proportions or relative risks of the event for a richer and more applicable interpretation of the data. So for example, one of the papers we see here is that during a median follow-up period of 10.4 years, when they reported this, so first they reported the summary statistics, after which they said that 64% of patients had the outcome, and then they reported the hazard ratio. So sometimes I think what we find when we're talking to colleagues or patients, it's easier to report the proportion, but for a richer interpretation of the data, taking into account all the information we have about the time to occurrence of the event, the hazard ratio is useful and important here for the statistical analysis. Okay, so I think what we would like to focus here again is just to remind you that this is the basic concept of a regression model. Understand the properties of a Cox regression model and how it works, and have some basic interpretation for Cox regression analysis. Yes, so I think with that, I'll just pass the time back to Dr.
Yeah, thanks, Orlanda. That was really a great lecture. So I hope everybody has a better understanding of this concept of Cox regression and proportional hazards, because we're going to be seeing this quite a bit in the next two talks. So without further ado, we have Dr. Cader to present on the Revive BCIS trial. Aisha, please.
Thank you, John, and thank you for the opportunity to present a synopsis and a brief critical appraisal of Revive BCIS 2. Okay, so in terms of background, we know that ischemic cardiomyopathy is the most common cause of heart failure worldwide. And we also know from the STICHES, that is the extended follow-up report, that surgical revascularization by CABG improves long-term outcomes to the tune of a 16% reduction in all-cause death. However, we know that surgery carries a major early hazard, as you can see from this Kaplan-Meier curve, which I will refer to because Dr. Goh has just told us what it is. And you can see that there's a crossover between the CABG and medical therapy arms, owing to the fact that there's an early from the surgical operative risk of CABG. PCI has lower procedural risks. We don't see this early hazard, and therefore has potential to allow benefits of revascularization without this early hazard. And before we move on to further hypothesis, just a couple of concepts on myocardial hibernation, which is relevant to both this as well as the STICH trial. Essentially, hibernation is an adaptation to recurrent ischemia, facilitating the myocyte survival in favor of contractile function. And this neat graphic is also credits to Dr. Ryan from a very nice review that was published this year. And this is the segment that we're speaking of. But as you can see, ischemic LV dysfunction is actually a spectrum. And we know that reversal of hibernation can occur by coronary revascularization. Further to this is the issue of myocardial viability testing, which is used to predict hibernation prospectively. However, there has been no prior randomized evidence comparing PCI versus optimal medical therapy in ischemic cardiomyopathy for the efficacy benefit and safety. And therefore, this trial is warranted because there is reasonable uncertainty, or what one would say sufficient clinical equipoise, and is therefore asking a valid question. There's also no prior RCT evaluating the value of viability testing in ischemic cardiomyopathy management. And based on the fact that there is no evidence, the ESC guidelines give it a class 2B level of evidence C in the absence of evidence. So the principal hypothesis for REVIVE-BCIS2 was that revascularization by PCI on top of optimal medical therapy would improve event-free survival and LV systolic function in patients with ischemic cardiomyopathy and a viable myocardium as compared with optimal medical therapy alone. And here OMT refers to individually adjusted pharmacologic as well as relevant device therapy for heart failure in the form of either CRT, CRTD, or ICD. So what is a patient population? The inclusion criteria for this required that patients have a poor LV function, which is defined as a left ventricular ejection fraction less than or equal to 35%. They also had to have extensive coronary artery disease as defined by a BCIS jeopardy score greater than or equal to 6, bearing in mind that the highest achievable BCIS jeopardy score is 12. And there also had to be viability in at least 4 myocardial segments which were dysfunctional at rest, and that can be revascularized by PCI. So the baseline LV function entry was by 3D echo or MRI, and the viability could be assessed by any imaging modality, CMR, DSC, SPECT, or PET. The patients they excluded were those that had acute MI of less than 4 weeks and acute decompensated heart failure preceding 72 hours, that is defined as those requiring inotropes, ventilation, or MCS, because these patients don't really fall into the hibernation category, and it could not have a sustained VTVF or appropriate ICD discharge in preceding 72 hours, as well as valve disease were also excluded. So in terms of trial design, this was a multi-center prospective randomized open label trial, randomized 1:1 to OMT alone or PCI on top of optimal medical therapy. Randomization was done by an online web-based system stratified by center, so one can assume that allocation concealment was secure. And this was an open label design because, of course, patients who underwent PCI would know that they underwent PCI, so they couldn't possibly blind them unless there was a sham arm, which isn't reasonable. However, this was mitigated by the fact that the endpoint adjudication was performed by an independent clinical events committee, and also the core lab was blinded to both the treatment assignment as well as the temporality images, where echo follow-up occurred at 6 and 12 months, and those assessing it did not know if they were performing the evaluation of either the 6, 12-month or the baseline echo. In terms of outcomes, the primary outcome was a composite of death from any cause or hospitalization for heart failure over a minimum follow-up period of 2 years. They also looked at major secondary outcomes, that is an LV ejection fraction at 6 and 12 months, as well as quality of life outcomes, the major secondary outcome being the Kansas City Cardiomyopathy Questionnaire overall summary score. Other secondary prompts included EQ5D5L, as well as the NYHA functional class. They also looked at a number of other secondary outcomes of importance, including, of course, components of the primary outcome and a health economics analysis. Now to power, and this is important in a randomized control trial. In order to extrapolate the result, there has to be adequate power. All-cause death or hospitalization for heart failure in STICH, as well as contemporary Western European registries. And they predicted that the predicted occurrence of death or hospitalization for heart failure at 2 years, which is the time point of the primary composite endpoint, would be 36% in the OMT arm. And at a minimum follow-up of 2 years measured over the entire duration of the trial, in order to acquire 85% power, they estimated a 30% relative reduction that is equivalent to a hazard ratio of 0.7 at a 5% significance. And this required 700 patients in total, 350 in each arm, and 300 primary outcome events. So this is essentially to the fact that in July 2014, that was less than a year after the first patient was randomized, there was a major protocol amendment where the ejection fraction was increase to 35 and less in order to make sure that it was easier to interpret and there was uniformity across the published evidence. And in 2019, there was STICH Viability long-term outcomes published, which Dr. Wong will present later. So in terms of the results, 700 patients were randomized 1:1, almost 1:1 to PCI and OMT. There was remarkable follow-up of over so that we can extrapolate the results only to this.
Ischemic, I think you got cut off quite a bit. The reception on your side seems to be a little bit.
I apologize. Yeah. Sorry, where did I get cut off? Do you know?
It's okay. We can continue from there. We just lost you for a couple of seconds, like 15.
Oh,
yeah.
I apologize. Sorry about that. I just said that in terms of results, 700 patients were randomized 1:1, and they analyzed all patients irrespective of loss to follow-up. Nevertheless, there was remarkable follow-up of over 99%, of 261 primary endpoint events. So baseline characteristics were well balanced, as is routine for a randomized control trial. And however, it's important to look at it with some granularity in order to make sure that we know which population we can extrapolate these results. Had no angina at rest. So this is important because these were not heavily symptomatic patients. The mean LV ejection fraction was about 27% across both groups, and the BCIS jeopardy score was 10, bearing in mind the highest is 12, which means that these patients had quite extensive coronary artery disease, and they also included left main to the tune of 14% in each arm in this trial. Other baseline characteristics of importance were that about a third of these patients had had a prior hospitalization for heart failure, and also the major viability assessment modality was cardiac MRI at around 71%. In terms of medications at baseline, there was good uptake of OMT, about 90% on an ACE inhibitor, ARNI, or an ARB, 91% on a beta blocker, and about 50% on MRA. Now, the primary composite outcome, and these curves are what Dr. Goh spoke of. They are Kaplan-Meier curves, and the hazard ratio is expressed by testing for a Cox proportional hazards model. And as you can see, in the PCI arm, there was a total of 129 events. That is 37.2% of patients had a primary composite outcome of either all-cause death or hospitalization for heart failure at a median follow-up of 41 months. In the OMT arm, this was to the tune of 38%. So this hazard ratio was 0.99, and meaning no difference. And the p-value was also not significant at 0.96. And also the results of the primary endpoint were consistent across these pre-specified subgroups that were predefined in the protocol. What about the primary outcome by completeness of revascularization? You can see again that the curves are almost superimposed, and the hazard ratio is close to 0.87 for PCI versus OMT, whether the resting index was greater or less than 80. In terms of components of the primary composite outcome, all-cause death was the predominant drive, over 2/3 of the events, as compared with hospitalization for heart failure, which was about 1/3. And they had two major secondary outcomes. One of it was ejection fraction, which in terms of quality of life indices, the major secondary endpoint was the Kansas City Cardiomyopathy questionnaire. And you can see there seems to be an early benefit for PCI. Oops, let me just. Have you lost me? Oops.
We got you back.
You got,
yeah.
Oh, sorry about that. I was just going to see if I could. Yeah, so I was speaking of the other major secondary endpoint, which was a patient-reported outcome measure, where there seemed to be an early benefit for PCI, but then there was a later catch-up. So at 2 years, there was no difference between PCI and OMT. Same goes for the EQ5D5L, which is another patient-reported quality of life measure. Similar distributions were present at baseline 6, 12, and 24 months, also for the NYHA functional class and the CCS class. Acute MI, which was another secondary endpoint that they looked at, was no different between the two groups. And of course, peri-procedural MIs only occurred in the PCI arm, but there were more spontaneous MIs in the OMT arm than in the PCI arm. And unplanned revascularization occurred more in the OMT arm than in the PCI arm, that is 10.5% versus 2.9%, as you can see from these Kaplan-Meier curves. However, it's important also to note that this was not something that the trial powered for, and therefore these findings are only exploratory. So in terms of a discussion, very briefly, this was the first RCT comparing safety and efficacy of PCI plus OMT on top versus OMT alone in ischemic cardiomyopathy with extensive coronary artery disease and a demonstrable viable myocardium. So this was testing a valid question, and this is an important component of EBM, that the question is valid and there has to be sufficient clinical equipoise in this specific population. In terms of the cohort and its applicability, LVEF less than 35% has been previously excluded from RCTs in stable CAD. So again, this is relevant. However, this cohort consisted of older patients, not overly symptomatic, and therefore this should not be extrapolated to symptomatic patients, I believe. There was extensive CAD, they included left main and CTO, and there was also good uptake of OMT. However, there was no SGLT2 inhibitors, presumably because there was no indication for this drug class at the time the trial was recruiting. So the effect of contemporary GDMT also remains to be seen. Furthermore, in terms of the trial design, we spoke of the fact that it is open label. Therefore, there was no blinding. However, this was compensated for by blinded endpoint adjudication as well as blinded core lab imaging assessment. And in terms of power, this was a superiority design with an 80% to detect 80% power, to detect a 30% difference of the primary endpoint at 85% power. The 30% difference may have been an overestimated effect size, not really in concordance with the moderate effect sizes one would expect from RCTs. And also they required 300 events, but fell just a bit short of that at 263 events. So whether it was slightly underpowered, I suppose Dr. Ryan can tell us. And follow-up, once again, was remarkable. And this was analyzed as appropriate by intention to treat. So in terms of results, there was still an unacceptably high mortality rate in both arms, 38%. So better GDMT is warranted. It's commendable that a patient-centric primary endpoint was used here, which included hospitalization for heart failure. However, the endpoint was ultimately driven by mortality. As for the quality of life and PROMS endpoint, could the early benefit of PCI be due to the open label nature of the trial? Remains to be seen. And other unanswered questions, or rather the elephant in the room indeed, is how relevant is viability? Dr. Wong will present later on the STICH sub-study, which showed no benefit of viability, although this was, of course, non-randomized and only mandated in the early phase of the trial with different definitions. And unlike STICH, in Revived, viability could guide treatment in PCI. 71% of them were assessed by a more standardized CMR, and could also be used to compare effects across the spectrum of viability. So I believe there's a segmental analysis as well coming up. And indeed, whether the improvement of LV function leads to better outcomes in this cohort of patients, as we did not see in STICH. This is basically a brief critical appraisal method. It's a neat checklist that you can use, which I'll skip in the interest of time and discussion. So thank you.
Thanks, Aaysher. That was a really comprehensive look into the study. And maybe I will start the ball rolling with a question for Matthew. So Matthew is one of the principal investigators and one of the co-authors of the paper in New England Journal of Medicine. I must say, at least personally myself, I was quite surprised with the results somewhat, when it came out. How do you see this influencing clinical practice?
So thanks very much. I think it's first, Aaysher, I think that's a really, really lovely summary of the trial. I've heard a few by now, and I think that's by far the clearest and best laid out. So thank you for laying it out so well.
You're welcome.
I think it is, Dhaka, as the chief investigator, set out to answer a specific question, but I think a really important question that people think is generally there. And that is, if you revascularize people with heart failure and coronary disease and ischemic cardiomyopathy, do you improve their heart failure outcomes? And personally, I think the trial has answered that question. I think the question of power that Aisha brought up is really important. We anticipated 300 events. In the end, we got 269 events. But when you consider power, it's of course really important to look at where the central point estimate ends up for your hazard ratio. And in our case, because the central estimate is so close to 1, even if you added in those additional 31 events, and even if they all fell into primary outcome events in the OMT arm, you still wouldn't change the outcome overall. You'd of course have some more uncertainty, but when you're so close to the central estimate, actually the issue of power becomes slightly less important as long as you're close. So from my personal perspective, I think that specific question we have answered.
Aisha, you have a question?
Yes, I actually do. It's about the viability. I would assume that you were somehow not privy to the STICH viability sub-study, but had you been, would you still have designed it by mandating viable myocardium into the inclusion criteria?
So again, it's a really good question, and I think there's two facets to it. One is the STICH data definitive, and is it definitive for PCI? And there, I think the STICH data is at the moment the best we've got. We of course hope in the very near future, and hopefully in the early part of next year, we'll get the viability analyses of Revived out and can add to that data. But at the moment, it's probably the strongest we've got. But it's a sub-study. It's of a selected proportion of patients in the trial. And I don't think it's the whole answer. The second question then comes for PCI. Can anybody come up with a biologically plausible reason that viability wouldn't be? Because we know PCI doesn't prevent spontaneous infarction the way that bypass can. We know PCI is predominantly about relieving ischemia. And so if your mechanism, if you're saying don't go via viability, what you're essentially then saying is either treat non-viable, completely dead myocardium, where it's hard to hypothesize what the benefit is, or treat normally functioning myocardium with PCI, in which case you're hoping for a ability to prevent spontaneous MI that you haven't seen in other trials, or at least without the cost of peri-procedural MI. So I don't think we would have changed it, but I think our viability analysis will hopefully bring forward some really important extra elements to this discussion.
I see, Kwan, you have a question as well, or a comment?
Yeah, congratulations, obviously, Matthew, on a phenomenal and really important landmark trial there. I had a question about COVID and its effects on the trial results. You know, the trial closed in March of 2022, which puts it, in 2 years, the patients were exposed to COVID, obviously on a populational level. There's an interesting, when you look at your Kaplan-Meier curves, there's an interesting separation, a reverse separation again, in a direction of favorability of PCI quite late on. And I was wondering, were you in any way able, and this is obviously outside of your control, and for all clinical trials that occurred during the time of the COVID-19 pandemic, I mean, this is the specific population in which you would have bad outcomes. And it is biologically plausible that patients who had been previously revascularized may have fared better during the thing. Were you able to do any kind of analysis to look at that effect?
It's a really great question. We haven't yet. As you say, recruitment, the final patient was recruited to Revive 2 days before the UK went into lockdown for COVID. At which point, of course, we were, while very busy running off to various intensive care units and other places, we also breathed a sigh of relief that the trial had completed recruitment. It affected follow-up in terms of the echoes, of course, and absolutely, it is biologically plausible that there might be a difference. They are a vulnerable population. I think we will do an analysis at some point. We'll look at a stratified analysis, as the Ironman team, many of you will have seen at AHA, presented their study of iron infusions in heart failure, and they did do a specific COVID analysis. And so we will do the same in due course. Again, I think the complete absence of a signal, because a substantial proportion of these patients went through before COVID, it's unlikely to change the headline result, but I think it's an interesting thing for us to look at down the line.
One question that I have, for the STICHES trial, the benefit for CABG only came up like in the longer term. Do you think, we are seeing some signal in the longer term that either PCI or medical, that will favor either PCI or medical therapy?
I think it would be, we'll definitely look at it. I think, again, the fact, and I guess we'll look at some of the STICH viability data, but the key thing with STICH is that it's always changing, right? And it comes back to the discussion about proportional hazards, because actually in STICH, the hazards aren't necessarily proportional. They changed at different times. For Revive, because everything's been very overlain, we don't anticipate there'll be a sudden big difference. But obviously there is a lot of interest. Ischemia have just published their extended follow-up. And so we certainly do plan, we've got ethics to run extended follow-up on electronic health records. And so the likelihood is we'll go out to about 10 years and get that extended follow-up data, because it would be a huge shame to miss a signal down the line if there was. So we'll get absolutely the most out of the data.
Maybe just to add on, there's been some commentaries as well as the comments that, that the patients recruited into the trial were not truly having severe ischemic heart disease. And there were some patients with double vessel disease, and the amount of interventions maybe in a single or double vessel only. Any comments or thoughts to that? Those
yeah,
comments?
Of course. So we certainly set out to define an ischemic cardiomyopathy population by, at the time, and I think still can in a contemporary manner, is the best and the best way you can. I mean, there is no magic test for ischemic cardiomyopathy. There's no one test you can send that says a cardiomyopathy is or is not ischemic. My colleague Holly Morgan, who's another author on New England Journal, has done some lovely work on looking at a threshold of coronary disease that predicts that an MRI will show ischemic cardiomyopathy, and a threshold of more than 6 is quite clearly linked. You have 90-something% specificity by the time you get to a Jeopardy score of 6. These patients did all have MRI, or the majority of them have an MRI, about 500, or stress echo. So they've all got evidence of scar. There is, of course, the question of 2-vessel disease, but the Jeopardy score is quite good, which means that any of those with 2-vessel disease are very likely to have had LAD disease, and probably proximal LAD disease. And again, the angiographic core lab analyses will come out. The extent of revascularization question is one that's come up a few times and I think is important, but it's important to remember that lots of these patients do have big areas of scar, and the protocol mandated that you treat viable myocardium and not non-viable myocardium. And so actually, if you think about it, the expectation is probably that the majority of these patients, or at least a substantial proportion, aren't going to get 3-vessel PCI, that a lot of them will get 2-vessel PCI because there'll be 1 infarcted territory or even 2 infarcted territories, and maybe a final vessel with viability within it. And there's going to be a whole spectrum of heterogeneity, and we have core lab analyses, further echo analyses, and the MRI viability analyses all coming through, hopefully in the next 12, 18, 24 months. And after that, from about the latter part of next year, we'll open up the data set to everybody to have a look at. So it'll be made freely available once all of the MRI, angio, echocardiographic analyses are there for people to take and explore and look at statistically, however they're interested in doing so.
Yeah, I mean, we are certainly looking forward to more data from this trial because it's really been a very instructive trial. So moving on, maybe we'd like to introduce our next speaker, Ivan, who's going to talk to us about the STICHES viability trial. Ivan, please.
Yes, hi. Can you see my slides?
Yes, we can.
Okay, thank you for your kind invitation. So this is Ivan Wong from Queen Elizabeth Hospital, Hong Kong. So the topic today is to present the STICH myocardial viability trial, and I will try to keep this short and simple. So just the background for these 2 studies. So on the left panel is the STICHES study. So it's the extended study of the original STICH trial, which was published 6 years ago. So it mainly investigate on whether the bypass surgery in patients with ischemic cardiomyopathy would have any survival benefit. While on the right panel, as you can see, is the STICH viability sub-study. So as which was published 3 years ago, and is of course is the sub-study to try to investigate whether if there is any impact from the myocardial viability on the long-term outcomes in patients randomized in the original STICHES trial. So just a few information on the background. So this is, again, this original STICHES trial is the prospective multi-center randomized and non-blind trial. And the patient enrollment, as you can see, is around like 15 to 20 years ago for the enrollment. And let's have a look of the entry criteria for the original STICHES trial. So basically is for patients with poor LV ejection fraction of less than 35%, and within 3 months of the entry of the trial. And of course, they must have a coronary artery disease, which was suitable for revascularization. But for patients with significant left main artery vessel stenosis of more than 50% was excluded in this STICHES trial. And this is the console diagram for the original STICHES trial. So as you can see, there's around 1,200 patients undergo the randomization, and half of them were randomized to the bypass surgery plus the OMT, and another half was randomized to the OMT alone. And they have the midterm results and also have the extended long-term follow-up of around, the mean follow-up period would be around 10 years. So as the extended study of the STICHES trial. And you can see from the baseline characteristics of the STICHES trial, and you can see majority of the study population are male. And you may also appreciate that quite a number of them have a history of previous myocardial infarct, as well as quite a number of them have quite other comorbidities. And of course, most of them also have the angina symptoms. And this is just very brief as the primary and the secondary outcomes of the original STICHES trial. And as you may all know that no matter the primary or the secondary outcome, namely the death from any cause, from cardiovascular causes or cardiovascular hospitalization, all the results point to a favorable of the bypass surgery when compared to the OMT. And these results would even be sustained in the long-term extended follow-up in the STICHES trial. So let's come back to the sub-study, which is the myocardial viability study. So in the original STICHES protocol, the tests to assess the myocardial viability were initially mandated, but of course later was discontinued because of the difficulties in the patient enrollment. So therefore, only a certain proportion of the patients in the STICHES trial were included in this myocardial viability sub-study, and they would define the myocardial viability by either the SPECT scan or the stress echocardiography. You mean back to like 15 to 20 years ago. And so therefore, in the original STICHES trial, there are 1,200 patients randomized, but in this sub-study, so only around half of them have underwent the viability testing. So either 300 each in each randomization arm, and only half of them have the paired LV ejection fraction. So around 300 of them have the paired LV ejection fraction, which means that they have the baseline LV ejection fraction assessment, and as well as the LV ejection fraction assessment 4 months after the randomization. So this is the primary outcome of the this viability sub-study. So of course, in this subpopulation of patients who have performed the myocardial viability test, the result indeed is quite similar to the original STICHES trial, which for the bypass surgery group have a better outcome when compared to the OMT group. And of course, if we try to stratify these patients with whether they have viable myocardium or not, as we can see that apparently with those patients with the viable myocardium, they apparently have better outcome when compared to the OMT group if they have the bypass surgery done. But if we look at the lower panel, as we can see that they do the cost-hazard proportional model, indeed the interaction is not significant, and we can see the p-value as well. So that's indeed we can appreciate that, of course, the patients with viable myocardium, the population is around 500, whereas for the patients without viable myocardium, they only have slightly more than 100 patients in this sub-study. And this is the assessment for the secondary outcome, which is the cardiovascular mortality. And again, as we can appreciate, it's a similar outcome in the KM estimate as compared to the primary outcome. So again, apparently the bypass surgery group in patients with viable myocardium, they have apparently a better outcome than the OMT group alone. And even as you can appreciate that the 2 KM curve would diverge upon the later years. So upon the closure of the follow-up period, indeed the 2 curves separate quite a lot. But again, if we appreciate the interaction, the p-value again is slightly is non-significant. And the authors also try to compare whether any improvement in the LV ejection fraction would affect the long-term outcome. And no matter whether the patients have the bypass done or not, or whether the patients have viable myocardium or not. So they just only stratified those patients in whether they have the improvement in the LV ejection fraction. So again, you can see there is not much significant difference between the 2 arms. And lastly, we can see that whether there is a change in the LV ejection fraction apparently is determined by whether the patients have the viable myocardium or not. So if the patient has the viable myocardium, regardless of whether the patients receive only the bypass surgery or with the OMT alone, they will still have the change in the improvement in the LV ejection fraction as compared to those patients without any of the viable myocardium. But of course, as we know, the improvement in LV ejection fraction unfortunately cannot extrapolate to the better survival outcome in the long term. So this, the authors therefore concluded that indeed the findings of these sub-study do not support the concept that the assessment of the myocardial viability can determine the likelihood of long-term benefit from the bypass surgery in patients with the impaired EF, the ischemic cardiomyopathy. And they cannot, and there is no any statistical evidence of the association between the viability of the myocardium and the benefit from the bypass surgery. And of course, this can raise quite a number of the debates and the dispute in terms of the result. But I would just summarize a bit on the different points in the discussion. So firstly is the sample size. And of course, we know that this sub-study is from the original, the STICHES trial. And because of the difficulties in the patient enrollment, so therefore, only a certain amount of the original patients would be enrolled. So it's around 600 patients. And as mentioned, as you can appreciate that the patients without viable myocardium is relatively a small number of around more than 100 patients. So this would be very likely that there would be the underpower of the study, resulting in non-significant of the interaction of the results. And secondly is the physiological complexity. So indeed, we are in this trial, they are treating patients with quite a diverse coronary anatomy and physiology, namely that as long as they have coronary artery disease, no matter it's a single vessel, 2 vessels, or as a triple vessel disease, they would be enrolled in this study. So So it's quite a diverse and heterogeneous group of patients. So, and again, it would be quite a bias in in this study. And thirdly is the cutoff of the myocardial viability. So in this study, they use either the PET scan as well as the SPECT scan as well as the stress echo, and they use a cutoff of a number of segments which are viable to cut off whether the patients have a viable myocardium or not. So, and they have this cutoff in sort of in a binary fashion. So again, they was pose a bias on the selection bias on the trial. And lastly is, of course, is the imaging modality suspension. So because this trial at that time, the majority of the imaging modalities would be still is the SPECT and as well as the stress echo, as compared to the REVIVE trial previously mentioned. This trial did not use any of the cardiac MRI, which would be nowadays is the gold standard to define the myocardial viability or whether the patient have other causes of the impaired ejection fraction or other causes of the cardiomyopathy apart from the ischemia. So these are just a few aspects of the to discuss for this trial. So in short, we try to summarize this trial with the pickle question is the relevant patients would be those patients with ischemic cardiomyopathy with impaired EF, and the randomize these patients whether they have the bypass surgery versus the OMT. And of course, the control is whether the patients, they perform the viability testing and to compare whether the patients have the viable myocardium have any difference in the outcome as compared to those without the viable myocardium. And of course, the outcome for this trial is that no matter there is any viable myocardium, the patients, the outcome of the bypass surgery because as compared to the OMT alone, will have a better outcome in the long run. So that's the end of my presentation. Thank you for your attention.
Thanks, Ivan. It was really, once again, a very comprehensive look into the STICHES viability trial. I've got a comment and a question. You know, in clinical practice, this group of patients with ischemic cardiomyopathy, low EF, is really a very challenging group to manage. And I mean, even for surgeons, you know, to operate on them, they really have to think twice or three times because sometimes outcomes may not be as good. So Philip, maybe I have a question for you. You know, looking at this results of this viability study, what do you think of the role of viability, at least in clinical practice, to select patients for bypass?
Yes,
Hey, John.
Yes, thank you for the question. So I guess, yes.
Ivan, maybe we ask Philip.
Oh, yeah, sorry. Yes.
Maybe for surgery-wise, you know, how has that impacted your practice? And, you know, are you still using tests to assess for viability prior to selecting such a patient for bypass?
John, thanks for the question. Can you hear me?
Yes, we can hear you.
Yeah, so I mean, previously when we didn't have such modalities, then it's not a question. We'll just probably be a bit more aggressive and just operate and see what happens, acknowledging that this is going to be at least a moderate to high risk group of patients. So, I mean, the previous speaker mentioned there's always an early hazard associated with CABG. So, and definitely higher in this group of patients with low EF and ischemic cardiomyopathy. So now with the current modalities which we can assess viability, so most surgeons would be more comfortable to at least have some form of assessment, because I mean, to subject this group of patients to a major surgery, we would prefer to have a viable myocardium where we at least think that we're resuscitating or restoring ventricular function. But the results of this trial are really surprising, and but of course there were some limitations as mentioned by Ivan earlier. So I mean, in today's practice, I would prefer to still use it. I mean, if there's for very poor EFs, I would still have an MRI done and see what is the extent of infarction and the viability. So of course, other factors come into play. Of course, each individual patient has to be, the management has to be tailored, whereby I mean, a lot of factors have to be considered. The quality of the coronary targets, whether they are good bypass targets, and the comorbidities, and of course, there was this mentioned earlier about how extensive or how many segments are non-viable. And generally, I think the cutoff is a bit arbitrary, but most, at least in our center, we are probably having a cutoff of 5 or 6 segments, where it is about 1/3 by MRI quantification. Yep.
Maybe I can ask Quan as well, like in the US, what's your practice like for your surgeons and your department? Do you all use viability to assess such patients? Or, or based on the STICHES results, you all just go ahead without any viability assessment?
I think in the United States where I've practiced, it's been about half and half. The STICH sub-analyses, I think, were quite compelling for a lot of people. So many people in the setting of ischemic cardiomyopathy have stopped using viability to decide with regards to surgery. But there are clearly many people who continue to believe in it. And, the modality of viability assessment is obviously very important. The unfortunate thing about the STICH trial is that, it was dobutamine as well as a SPECT, and now we have MRI. And so that question has not been tested yet. So there's clearly possibility, biological plausibility that form of viability assessment is important. I think overall today as well, for me, it's obviously a three-way question, right? Which is superior, medical therapy in this cohort, surgery in this cohort, or PCI revascularization? In our most recent ACC guidelines, clearly it's still a class 1 indication, just because the 10-year follow-up data from STICH is so compelling, right? Compared to the initial paper, which was neutral. As long as you stretched it out, it was better. The one thing I would say, though, obviously, the recent studies, Revive, is very important, but for me, there is still a cohort for which I'm a little uncomfortable with trying to make generalizations. If you look at the STICH data, the median age of enrollment was 60 years old. And when you look at Revive, the median age is 70 years old. And within the STICH cohort, the younger patients, the patients who were less than 60 years old, their hazard ratio was 0.75. It was very strong in the direction of revascularization benefit versus medical therapy. The patients who were greater than 60 years old, it actually crosses 1 at 0.91. When you look at the Revive data, you get a soft signal there, but it's definitely headed in the direction. The less than 70-year-old patients had a hazard ratio of 0.86, and then the greater than 70-year-old had a 1.07. And you have to remember that the primary endpoint for Revive is just 2 endpoints, right? Hospitalization, which accounted for 1/3 of the final endpoint, and then death, which accounts for 2/3, while STICH is primary endpoint is death. So that's a much higher powered study. So it's still entirely possible that, for me, it solidifies this is probably not in contemporary medical management, excluding SGLT2s, in older patients, it's probably not the best thing to do to push revascularization. But in younger patients, I'm still concerned that we might be missing an opportunity if we try and generalize this study's outcome to 50-year-olds or 45-year-old patients,
That's a really good point. I mean, at least from a common sense point of view, the younger you are, you may accrue the benefit of revascularization over time. Matthew, are you there? Would we be able to ask you, what you think about what Quan mentioned about the age kind of subsets? Do you think the younger age group would show more benefit, at least for the BCIS study?
It's a really good question. When you look at our, and I completely agree with the point. When you look at our figure of the subgroups, you see a lot of those same trends as STICH. You have to be very careful because statistically none of them are positive. But in STICH, younger patients, more coronary disease, poorer LVs were all directions which in subsequent analyses showed benefit. And I agree. I think particularly, though, my takeaway is I really buy STICH. I know there's some in the heart failure community who don't. There's people who've raised questions about where the patients were recruited, were they very selective? You know, in the entire United States, only 125 patients went into STICH, which is the same number as St. Thomas's Hospital put into Revive. So it's selective, but the bar of an RCT is really high. And I personally do buy an 18-month survival benefit in ischemic cardiomyopathy from having a bypass. And I think those patients should definitely still be investigated. And if they're bypass eligible, I think they should have surgery. Should they have PCI if they're not candidates? I guess the problem then is what's making them not surgical candidates. Is it that they've got a lot of comorbidity? Is it that they're, you know, frail? Are they biologically beyond their chronological age? I think that's a cautious discussion. With a good thing from Revive is we know there's no signal of harm. That's a really good thing. So for ACS, for angina, you know, we don't have specific data, but it's probably good stuff to be doing. I think that question, again, we need to look at the data, maybe do some comparative analyses of the young patients with the STICH investigators. But I think they should be worked up and considered for bypass surgery, because I think it is an effective treatment.
At this juncture, we have a question from one of the audience, from Harris. Maybe I would like to direct this to Matthew first. So Harris is asking, you know, whatever is the outcome, be it a death or heart failure hospitalization, is the completeness of the revascularization important? So meaning that, you know, PCI provides less complete revascularization than CABG in this case, hence the differing outcomes. You know, any thoughts on that?
Yeah, it's I have a sort of particular interest in completeness of revascularization, and particularly it's just something I continue to try and get my head around. I think it's hard enough in your normal LV type population. Once you get into a poor LV population, your whole way of doing revasc is different. With PCI, you're going to be selective. You're going to select the more viable territories. You can do it sequentially. So you can do one, come back and do another. Bypass is completely different. Your procedural risk is all taken up in your decision to operate. And then a surgeon will graft everything. And so your mechanistic difference in different territories is going to be different. You know, you can imagine a patient who's got, you talk about completeness of revasc, but say you've got a patient who's got an infarcted circumflex and right coronary territory, a 90% proximal LAD, and your surgeon puts a lemur on that LAD. Have they had partial revasc? Have they only had one of their 3 vessels treated? Or have they had complete revasc? Have they had everything fixed that's actually important because everything else is infarcted? But could there be an effect of arrhythmia on the inferior territory where there's pools of infarction? The complexity is really high, but it is a good question. I don't think anyone will really be able to tease it out, other than to say that where you are revascularizing, I think, as always, there's always going to be a mandate to try and do as much as possible within the bounds of safety, and surgery is generally better at achieving that.
That's a really good point. Maybe I have a statistical question to ask. Is Orlanda there? So, you know, in the subgroup analysis for viability, we saw that in those with viable myocardium, the forest plot showed that CABG was favored, but overall the p-value for the interaction was not significant. And so the overall interpretation is that viability does not impact outcomes in this group of patients. Do you have any comments on that? Could we just look at that forest plot that favored CABG and say that, you know, there may be some signal there with a non-significant
Yes, so I
p-value?
think the point to take home would be what the value of an interaction model would be. And I think sometimes it might be confusing because people might think of that and also think of an effect modifier kind of approach to analysis. So I think it's basically important to just understand that when you're talking about interaction model in the statistical analysis, they would be modeling whether actually, in this case, myocardial viability could add or subtract to the effect of the intervention. And when they're modeling it, it's basically they're seeing if you were looking at thinking of the curve as a y equals mx plus c, whether it changes the gradient, and or essentially whether there's antagonistic or synergistic effect. So I think the take home for this, by looking at it, when you see that there's not a significant p-value, then you can take home the message that it doesn't mediate the relationship between surgery and the outcome. And in the end, based on the outcomes as they presented in the earlier graphs and the tables, it is as it seems, and myocardial viability does not change that relationship. And this is as opposed to perhaps what we might see sometimes in effect modifier kind of analyses, where traditionally you do a subgroup analysis among those who had demonstrable myocardial viability and those who didn't, and you look at whether and the question you want to answer is this subgroup a group that you want to select for the intervention? So I think 2 take-home messages would be to understand the concept behind that modeling, and also just to take home from that, from what we see here, that we don't see a significant difference or significant interaction in this case.
Thank you.
So I think we've come to an hour. It's really so fast when things are getting interesting. I'd like to close the session by firstly thanking our 2 speakers. A wonderful presentation, beautifully critiqued. And we learned a lot from Ivan's presentation and his thoughts on STICH, as well as Aisha's presentation on Revive. I love this 2 critical appraisal. And of course, the expert comments from Kwan, Philip, as well as Orlando on the meta-analysis part of it. Sorry, the analysis part of this. Personally, I think there's still lots of work to be done, but I think these 2 trials give me a few pointers in this current day and age. Very poor EF, multivessel disease, particularly in those in heart failure. What I learned from STICH is that CABG is probably still the way forward if suitable for this group of patients. I'm not too sure whether we should obsess about a mechanistic rationale. I think the trial needs to seek to prove that it works. At least in STICH, whether it's viable or not, there is benefit for complete revascularization. I think CABG does provide more completeness. And then what's lacking in Revive, I feel, is that we're too obsessed with viability. I still believe my old surgeons telling me that if you keep the artery open, it still gives some form of stability, especially against arrhythmic events or cases, even if the myocardium appears to be dead, but I don't know. So it still needs to be proven. So Matthew, more work for you there. So I look forward to more publication in the realm. The other I learned from Revive is that we don't have to rush in. Patient is having active heart failure, very sick. Let's wait a little while. Let's optimize the therapy and bring the patient back to have a discussion, MDT, on whether the way forward is bypass or a high-risk PCI. But I think the patient doesn't derive a harm by waiting. And of course, in this case, it doesn't derive a major harm by proceeding with limited ischemia-guided or viability-guided intervention. So that's why I learned from the Revive trial, which is very nice, and we hope to see longer-term results. I would let my surgeons have the first cut though, so Philip will continue to have a lot of work, and he will continue to bounce them off if he thinks it's not viable. So I will have a lot of work too in this high-risk subgroup. So thanks, Philip, for that, and wonderful comments from everyone, and thanks for John for chairing the session. So I'll look forward to the next APSC Journal Club, and thanks for your time and attention for today. Thank you very much. Bye-bye.
Thanks, everyone.